Good afternoon, everyone in Europe. Good morning from people that's connected from America, and evening from people connected in Middle East or Asia. Thank you to all attendants for being here. I would also like to thank you to Complex, the manufacturer of the JET brand, especially Mr. Nespor for allowing me to moderate this webinar. It's a webinar of ophthalmologic indications of the device JET Plasma. JET Plasma Lift is a device that we have been selling for more than 5 years, and every day is giving us new surprises in forms of new applications in different fields of medicine. Some years ago, we approached to the ophthalmologist, mainly in the oculoplastic applications, but we discovered that the device could be used in other pathologies thanks to its unique features of direct current. That's patented by JET. As doctors will explain it better than me, I will only present them now, and we will go straight to the presentations, okay? The program of today's webinar is as follows. First of all, Dr. Vicente Rodriguez from Canary Island in Spain, that he's an experienced ophthalmologist and he's scientific advisor of the company. Will explain us how the device works and what are the main applications. After that, Dr. Tadaki Yamada from Sao Paulo in Brazil will share with us his great experience in blepharoplasty using the device with, I think, more than 400 treatments done. In third place, Dr. Rafael Melian from Canary Island as well will explain his experience using the device in xanthelasma. It's another very common application of the device. Following that, Dr. Ivana Masejova from Czech Republic that has a huge experience in all ophthalmology applications, collaborating from the beginning with the company. Will share with us her experience in other oculoplastic uses like entropion, ectropion, or trichiasis. And finally, Dr. Carlos Ruiz Lapuente from Barcelona will talk about dry eye disease. The treatment with JET Plasma that's very promising, and it's again available thanks to the patented technology of direct current. And finally, he will also share the latest data of the clinical studies. And if we have time, with so many subjects after the presentation, we will have some Q&A time and common discussion. So please, if you have any question during the meeting, please write it down. We will answer at the end. So again, thanks to all participants. And now it's time for Dr. Vicente Rodriguez to start his presentation. I will make you presenter. And let's start, Dr. Rodriguez. Yes, Martin.
I have a request to all persons. Hello, my name is Martin, and I'm here for the Complex company. I would like to ask all participants of this meeting, could you please try to turn off your cameras so that the connection of your computer is usually more stable once you have stopped sharing your camera. So thank you very much and enjoy the presentation of the doctors.
Okay. Okay, hello. Good morning, good afternoon, good evening, everybody. First of all, I would like to thank Albert at Medicalio, Martin and Ravex at Complex for organizing this interesting meeting. For the last few minutes, I would like to present my experience in JET Plasma Lift Medical and its main indication in ophthalmology. I am working in corneal surgery, in refractive surgery, and in ocular surface diseases for the last 30 years. And for me, it's very important to know very, very well all the devices for working and treating dry eye disease. Currently, I am very happy with the result that we have Jet Plasma LIS medical device, because it's a very versatile device that we can use in ocular surface disease for treating dry eye disease secondary to meibomian gland diffusion and blepharitis, but as well as in oculoplastic procedure, as you can see during my presentation. The plasma LIS medical is a medical device. It's plasma technology, generator of plasma discharge, very compact, lightweight, and very versatile, with a special pen designed for us for ophthalmology, with an ophthalmology set.
Ophthalmology set. Jet Plasma Lift Medical and Plasma Pen. 5 silver applicators and 2 golden applicators. 5 ophthalmology applicators.
Isn't easy to see plasma in nature, but we can see plasma every day. We are looking the sun. The sun is here a huge ball of plasma.
But you can still observe it as thunderbolts or lightnings. Artificial plasma can be generated by continuous transmitting the energy to the gaseous material. Jet Plasma Lift Medical uses direct configuration, thus creating this spark flow area of only 0.1 square millimeter. Plasma beam can be observed up to 4 millimeter above the skin, so the treated area is clearly visible, thus improving precision. This mechanism of direct current discharge, in contrast to discharge caused by alternating current device, affects a much smaller area of the skin. This results in more precise treatment and no damage for the surrounding skin.
But why Jet Plasma Lift Medical uses direct current? Because this allows us to work with a continuous beam, concentrated spark using a diameter only 0.1 millimeter, high voltage 5,000 volts, distance to the skin less than 4 millimeter, more precision in sensitive area for working around the eyes. It allows the use of different tips and applicators. We can work using dot by dot and scanning method discharge, and to be able to use silver hits for cosmetic, periocular, and facial treatment. Plasma is not laser. Plasma is not radio frequency. Plasma is energy, and it acts only superficially, produces tissue sublimation. When we are working with Jet Plasma Lift, we have the possibility to do ablative surgery and non-ablative surgery with our ophthalmology set. And we have, for us, for ophthalmologists, 7 applicators. 2 golden applicators for ablative procedures, for example, blepharochalasis and telasma, ectropion, and also for severe meibomian gland diffusion and blepharitis, and 5 silver applicators for the treatment of mild or moderate meibomian gland diffusion and for periocular and facial rejuvenation. But how does this work? The plasma lift medical treatments uses plasma, the first state of matter beyond solids, liquids, and gases, in which electrons separate from atoms to form an ionized gas that becomes highly charged, transforming into a continuous flow of plasma that stimulates the formation of new collagen and elastin fibers. Spark discharges generate heat that warms the skin. We can work with a device with 8 intensities and 7 applicators. In dry eye disease, how does this work? For treating dry eye disease, especially secondary to meibomian gland diffusion and blepharitis, the potential mechanism whereby Jet Plasma Lift could achieve clinical improvement include thrombosis of abnormal blood vessel, heating and liquefying the meibum, activating fibroblasts, and enhancing collagen synthesis, eradicating the motics, very important, eradicating the motics, decreasing the bacterial load on the eyelids, modulating the secretion of anti-inflammatory molecules, reducing the turnover of skin epithelial cells, and decreasing the risk of physical obstruction of the meibomian glands. The plasma leads can be easily transported between from one office to another office, between different operating rooms, and even it's very easy for moving between different clinic, different centers. When we are working with this device, we can use intensities 1 to 5 for cosmetic treatment, with the silver applicator for periocular skin tightening, removal of fine wrinkle, for example, periocular hydration of improvement of elasticity of periocular skin, and intensities 6 to 8 for tight treatments, for example, blepharochalasis, removal of warts, scars, pigmentation, spot, telangiectasias, entropium, ectropium, etc. The plasma pen applicator is activated by the switch located on its handle, ensuring optimal use and mobility while remaining connected to the Jet Plasma Leaf Medical. It is a lightweight and ergonomic extension designed for us for use specifically in ophthalmology, and is an extension of the device's main body. But we can use Jet Plasma Leaf with everybody. Unfortunately, no. We have some contraindication. Before treatment, we need to inform the patients about contraindication, which would exclude treatment, such as patient with pacemaker, Holter, other implanted electrical devices, epilepsy, pregnancy, metallic implants present in the treated area, skin diseases, acute inflammatory body disease, acute oncological disease, or even allergy to the local anesthetic. I recommend to check the line of the hand, because in patients with correct phototype, for example, phototype 3, even 4, but with very pigmented the line of the hand, the risk for to have hyperpigmentation is created. To avoid risk of hyperpigmentations in periocular rejuvenation in blepharoplasty in patients with phototype 4 and 5, it is recommended to use a hypopigmentation cream 2 weeks before, together with sun protection, and 2 weeks after the treatment. You can see my personal formula for treating before my patients for avoid the hyperpigmentation, but currently it is very easy to obtain in the pharmacy, many brands, as you can see here. About dry eye disease, meibomian gland diffusion is the most common cause of dry eye, affects between 55 to 86 of all affected patients, and it is treatable in a very efficient way, since in severe cases inflammation of meibomian gland degenerates in atrophy and disappearance of the glands. Dr. Ruiz de la Puente later will talk about his experience with Jet Plasma Leaf Medical for treating patients with dry eye disease and with blepharitis, using the golden and the silver applicator. Dr. Tadaki will talk about blepharochalasis, and he will present his experience in Jet Plasma blepharoplasty. It is a minimally invasive procedure. All the ablative procedure when we are working with Jet Plasma Leaf with the golden applicator are minimally invasive procedure. About the possible side effects, we need to know the post-inflammatory hyperpigmentation, but is highest in phototype greater 4, in smokers line, and in very aggressive treatment, But using the hypopigmentation cream, the rate is very low. It's near zero. The eyelid edema is frequent after blepharoplasty, but the big eyelid edema during for the first days after the procedure is very important to check if our patients use tricyclic antidepressant, because in this group of patients is more frequent the big eyelid edema. About very slight transient hypopigmentation does not require treatment. The hypervascularization is very rare, and their correction is no problem because we can prepare a second treatment three months later. And in some group, for example, in Asian population, Japanese or Chinese population, in some cases, I prefer recommend two procedures, two blepharoplasty and the correction, because this group has a bigger risk of hyperpigmentation. But treating before the skin with hyperpigmentation cream and after 2 weeks, before 2 weeks after, the risk is very low. Many of our colleagues prefer to treat crow's feet with botulinum toxin, but in my opinion, to use jet plasma leads for treating crow's feet is very interesting, because you can see this patient, the result was very good. But it's very important to know in crow's feet, it's very important to use a dot-by-dot method on the edges of the wrinkle and not in the center. As you can see in these patients, we combine treatment for treating crow's feet and low and mild blepharochalasis, blepharochalasis. For treating the crow's feet, I need to do the dot-by-dot on the edges of the wrinkle and not treat in the center. This is very important. In some cases, for example, in these patients, we can combine the ablative procedure with non-ablative procedure, golden applicator and silver applicator. Golden applicator for treating the crow's feet, and silver applicator for lower eye, for wrinkle on the lower eyelid with painless treatment. For treating the crow's feet, we need to use or local anesthesia, lidocaine 2% normally, or even anesthesia in cream, lidocaine 20% of concentration in cream. It's enough in many cases for treating crow's feet with golden applicator. And you can see that the result is very good, combine golden and silver applicator in the same procedure. I like a lot to treat pericular lifting with jet plasma leaf using the silver applicator, the silver applicator, because a cosmetic procedure has visible result immediately, and it is completely painless with a long-term effect after several sessions, normally for 6 sessions, and we can combine this pericular lifting with facial rejuvenation. As you can see, between 6 to 10 sessions, treatment about 30-50 minutes, painless using, and we have 2 options. Use the ophthalmology set and the ophthalmology pen with the flat 10mm applicator, or the bigger one, the bigger applicator of the main device. We can use the plasma for treating eyelid warts with very interesting result. As you can see in the image, is an ablative procedure. We need to use a little of local anesthesia and with the golden applicator. Dr. Melian will talk later about xanthelasma, but I would like to say that I recommend my ophthalmologist friends who want to start with jet plasma leaf that they do it with xanthelasma, because the results are excellent. If you begin with jet plasma in a patient with xanthelasma, you will want to use this device in other procedure, because the result, in my opinion, for Santelasma is amazing. Dr. Ivana Masejova will talk about the ectropion, entropion, and trichiasis later. And this is a very interesting case, because every time it's more frequent the solar lentigo associated with aging and exposure to ultraviolet radiation from the sun. This type is common in people over age 40, but younger people can get it too. And the treatment will be a scanning method using golden applicator with a local anesthesia, but every time more colleagues prefer to use lidocaine 20% on cream, or even a combination between lidocaine 23% plus tetracaine 7% cream. In many hospitals, in many lab, you can obtain in your city this formula for treating using numbing cream and no use the injection of lidocaine. Even these patients who came for a hyperpigmentation spot on the wing of the nose with a marked picture of periocular acne and facial in general. The periocular acne is very easy to treat. It's silver applicator. We need to use a gel on the skin and work on the gel with the silver applicator, normally 3 millimeter, working on the next dot, and finally we can finish the procedure with 1, 2, 3 seconds of discharge with the conic applicator on the dot of the acne. Is a good option, jet plasma lead, for treating telangiectasias, Avladis procedure, golden applicator, dot by dot method, as you can see, and in the most of the cases with lidocaine in cream is enough. In conclusion, development of new treatment for dry eye disease, jet plasma lead medical can contribute to achieving stability of the ocular surface in patients with meibomian gland diffusion, because 75% objective improvement with 1 or 2 sessions, and plasma flow stimulate formation of new collagen and elastin fibers, and it is a device very versatile for oculoplastic surgery, periocular and facial rejuvenation, and currently every time more for treating dry eye disease secondary to meibomian gland diffusion and blepharitis. Thank you.
Thank you very much, Dr. Rodriguez. Now it's time for Dr. Yamada, and let's see if we can find you. Yeah. So whenever you want, Dr. Yamada, you can explain us your experience in blepharoplasty.
I will start my presentation. Thank you for organizers, Martin and Albert, and thank you for Dr. Vicente that helped me in my presentation. He explained very good indication for eyelid rejuvenation. Last year, I participated some webinars, and all of them, when you talk about the eyelid rejuvenation, they talk about plasma technology. Okay.
Perfect.
Again, thank you for invite. I'm very honored to be here, and today I want to share my experience in eyelid rejuvenation using plasma technology. Last year, I participated so many web meeting, virtual Vegas Cosmetics, and IMWC Monaco meeting. And when you talk about eyelid rejuvenation, all the doctors nowadays talk about the plasma technology. So today I want to share my experience to treat superficial and deep wrinkles and eyelid rejuvenation. These technologies, it's indicate for the patient who fear of the surgery. Procedure can be performed at the clinic with local anesthesia, lower the costs for the patients because you don't need the sedation. And the main advantages compared to the conventional blepharoplasty is no incision, no suture, and no scar, and completely recovery in 1 week. I participated the first meeting in Berlin, and Dr. Matus Baram, he showed these protocols. In red, you can see the scanning technique, and dot in green is dot by dot. Scanning technique, you take the device and make the continuous movement horizontally or vertically, and you are treating only the superficial layer, the epidermis, and the heat in the skin, you will promote the neocollagenesis and the retraction of the skin. And if you take the device and stay in the same position for 3 or 4 seconds, the plasma will achieve the papillary dermis. Comparing to scanning technique, dot by dot promotes more retraction and more neocollagenesis. For upper eyelid, you combine the scanning and dot by dot, and for lower eyelid, you use only a scanning technique. Protocols for eyelid rejuvenation. As Dr. Vision said before, prepare the skin 2 weeks before the treatments with hormone skin in Brazil and Neuretin in Europe. Use the anesthetic cream 30 minutes before the treatment. Patient can take Tylenol or another analgesic pills 30 minutes before the treatment. Then I infiltrate 2% lidocaine, 1.5 or 2 cc each eyelid. This is the video of the technique. Here, about 10 millimeters from the edge of the eyelid and the eyebrow. The lower eyelid, I start with the orbital ring to 5 millimeters from the edge of the eyelid. Now I'm using the lidocaine 2%, and I set the device intensity 7. Now I'm starting the scanning technique. The skin got whitish, the color of the skin, and then I start the dot by dot. You can see more retraction comparing to the scanning technique. And now for the lower eyelid, I use the intensity 6 and start scanning. It's important to demarcate the crawl fit, and the treatment is beside the depression. And after the treatment, keep the treatment area dry for 3 days. Dryness helps to scab formation. And after 4 days, I start using Cicaplast. It's a cream that contains panthenol, glycerin, and zinc. I use for 1 week. And after 4 days, I recommend to use the sun cream 4 times a day and wear sunglasses. And after 1 week, use again the hormone skin for 2 or 3 weeks to avoid the post-inflammatory hyperpigmentation. This is the cream to prevent the hyperpigmentation. I recommend for all the phototypes, even 1 and 2. And here, the patient from the video. She was complaining about the crawl feet. Here's before and after 3 months. You can see the aesthetic wrinkle reduce. And another side, you can see the
Dr. Tadaki, sua apresentação não está aparecendo.
Ué, aqui no meu tá aparecendo.
Sorry, what's the
No,
problem?
it's okay, Tadaki.
It's
We
okay
can see.
with presentation?
Yes, we can see.
Okay, and so you can combine, after 2 weeks, you can use the Botox to reduce the dynamic wrinkles. Here before the treatment. Here the picture 1 day after the treatment. 4th day, the scab start to peel off and you add the cream to hydrate the skin. And here, complete to recover after 1 week. Here, before and after 1 week, you can see the retraction of the skin. The eyelid rejuvenated. Here's another patient, first 5 days after the treatment. Another picture after 2 weeks. Erythema could persist for about one month, depend of the patient and depend of the intensity of the treatment. Here, after 1 month, you don't see any erythema. And here, after 2 months, patients are very satisfied with the treatment. Here, another patient before and 1 day and 2 days after the treatment. Scanning the lower eyelid and for upper lid, combination of the scanning and dot by dot. Here, after 1 month, and here, the picture after 3 months. The best result you will see after 3 months. So, if the patient desire to improve the result, you can do after 3 months, because the nail collagen is still continue after 1 month. Here, another patient, May, he was complaining the upper and lower eyelid, and I do the same protocols. One month after the treatment, a good result. He's very happy. And now I will show a workshop that I went to Japan 2 years ago. And the patient complained about the lower eyelid. But in this case, the best indication is take the fat off surgically and then treat the skin. But the patient want only the jet plasma treatment, so I did the scanning with intensity 6. The patient was very happy because the skin tightening reduced the appearance of the fat. But fat is still there, but the skin tightening reduced the fat appearance. Another lower eyelid treatment, she was upset with her eyelid. So I did the scanning, and between the horizontal wrinkle, I did the dot by dot. Here's after, before and after 3 months. Good reduction and the skin tightening of the lower eyelid. Good results. So for phototype 1 and 2, I do this protocol, but I have about 4% of hyperpigmentation in phototype 4. So I think another technique to improve my results for the Asian patient and for phototype 4, but safer technique, but with good results. So I show the hybrid technique at the meeting 2018. I called hybrid technique. I divide the eyelid in 2 parts, the upper lid. The lower part is in red. When the patient opens the eyes, the demarcated area disappear. So in this area, I do the scanning and dot by dot, the combination, the stronger treatment. And the area in blue, when the patient opens the eyes, the blue area appears. So I do only the dot by dot. So I call the hybrid. Okay, in red, I did the scanning and dot by dot. And in blue, I did only dot by dot. Here's the video. I use this technique for phototype 4 and for young patients because it's heal faster than protocol for whole eyelid. In red, I did the scanning and dot by dot, and in blue, I do only the dot by dot. This technique, what's happening if the patient has the hyperpigmentation? When the patient opens the eyes, nobody will see because it's hidden part. And dot by dot, comparing to the combination, has less intensity, so less chance to hyperpigmentation. Here, the patient complained the upper and lower lid. For the upper lid, I did the hybrid technique. Here's day 4 to 7, complete healing. And here, after 1 month and after 6 months, patients are very happy with the treatment. Here is the Asian patient, phototype 4, I consider, after 3 days and after 2 weeks. Now you can see the sulcus, and here after 6 months. She is very pleased of the results also. Here's a young woman. She's complaining about the double wrinkles, double sulcus at the upper lid. I did the same technique, hybrid. And here's the results. After 1 month, disappeared the double sulcus of the upper lid. So last 6 months, I started using the drug delivery right after the treatment of jet plasma. You do the scanning or dot by dot, and then you put the liquid that contain drug delivery that enhance the neocollagenesis and prevent the hyperpigmentation. Clarifying it's for melasma and to prevent the hyperpigmentation, and age and firmware promote more neocollagenesis. Side effects, in my experience, I had about 4% of the patients, but this complication is transitory. It's disappear about 4 months. It starts to appear about 1 month and disappear after 4 months. Hypocorrection after 1 session is about 3.5%. 11 patients asked for another treatment, another session. And all the patients of hyperpigmentation was phototype 4, 7 Asians and 5 Brazilians. All of them was treating only with the cream, micronized hydroquinone, and clobetasol. And I did the peeling of retinoid acid 5% every 2 weeks. And 1 patient was treated with picture laser, and 100% success rate after 4 months. So this is the risk for hyperpigmentation, higher phototype types, smoker, and aggressive treatment. Here, just to see what's happening, hyperpigmentation of the right side, because the doctor, it was during the workshop, the doctor that treated the right side used the scanning and dot by dot in the inferior lower eyelid, and the doctor that treated the left side used only the scanning. But after after 1 month and 4 months, here completely recover the hyperpigmentation. So with 12 patients, 10% of disappear after 4 months. Here. So this paper, this article, said that dots is preferable comparing to the scanning. Dots has less hyperpigmentation compared to scanning techniques, and they recommend to prepare the skin before and after the treatment. Here, it was in Japan. We used the picture laser, and after 1 treatment of picture laser, complete recovery. There is another article from Brazil using the jet plasma for upper eyelid blepharoplasty, and their rate of satisfaction, 75% of the patients willing to do again if they need. So almost all of the patients are very satisfied with the plasma rejuvenation. Take home message. So it's very important to prepare the skin 2 weeks before the procedure. I always use the intensity 6 or 7, don't need to go at 8. 6 or 7 is enough. For phototype 1 and 2, you can use the scanning and dots by dots combination for upper eyelid. But for phototype U4, I use only dot by dot for upper eyelid or hybrid technique. And for lower eyelid, you can or use the scanning or dot by dot, not the combination for lower eyelid. And for phototype 4, it's very important to explain that maybe need more than one session. And after day 7, use the hydroquinone, tretinoin, and fluocinolone to avoid the hyperpigmentation. Hyperpigmentation may occur, but it's transitory, and it lasts about 4 months. And to conclude, eyelid rejuvenation by jet plasma is safe and effective. The advantages comparing to conventional blepharoplasty is lower costs. You can do under the local anesthesia. And the main advantage for me is no incision, no suture, and no scar. As any other device, patient selection is the case to success. Thank you for attention.
Thank you very much. Thank you, Dr. Yamada. It's very, very interesting presentation with great experience from your side. So from now on, we will go to Dr. Rafael Melian, who will share with us his experience with shunt elasma. Oh, okay, I see you are ready. Whenever you want, Dr. Melian.
Yes.
Thank you.
Thank you very much. Wait a moment. Now, just now. Okay. Good evening, and thank you very much to the organization for inviting me to this webinar. My name is Rafael Milian, and I'm going to speak about my experience with jet plasma lift in shunt elasma. Congratulations to Dr. Rodriguez and Yamada for your presentations. Mine is shorter, and I will divide it in 3 parts. First, a small introduction about shunt elasma. Then I'm going to talk about my initial feeling with jet plasma lift, and I will conclude with my results. The shunt elasma is a type of xanthoma appearing on the eyelids. Xanthomas are deposition of yellowish cholesterol-rich material, similar as we can see in this picture. There is a family predisposition, and it can be related with hypercholesterolemia and diabetes, or stress and tobacco. In most cases, patients come to our office asking for surgery because it is the traditional and most famous treatment for shunt elasma. It could be a simple resection or a blepharoplasty, depending on the skin presented on the eyelid. Surgical is a great option, of course, but we must know the scar risk, especially in the lower eyelid, and the bleeding or lagophthalmus risk. Laser, another good option could be the laser. There are different kinds of lasers, but the most used is the CO2 laser. It is a good option, but if we want to minimize the pigmentation risk, we have to decrease the energy of the treatment and perform several sessions. Some doctors used to do chemical peeling with trichloroacetic acid in different concentrations, 30, 50, 70%, but the higher the concentration, the lower the number of sessions, but the greater the risk of scar and ectropion. And finally, the plasma. If we do it correctly, we will only need 1 session. The scar or pigmentation risk is almost 0, and it is an affordable treatment, and as we are going to see now, it is really easy to use. About my initial feeling with jet plasma lift, it couldn't have been better. As I said, it is very easy to use, so the treatment can be done by any ophthalmologist. We just have to know which buttons to press and which applicator to use according to the energy. It is very comfortable for the doctor and patient, and especially for ophthalmologists, the plasma pen, because it is not bigger than a pencil. For the treatment, I use lidocaine 2% under the shunt elasma, and here in the video, yes. And then I use the golden applicator and high energies to sublimate the shunt elasma. And as we can see in this video, When the injury turns black, we have to clean the black bed and continue sublimating. Now I'm sublimating it in the borders, as you can see. Then when it turns black, we have to clean, removing the black bed, and we have to continue sublimating until reach the skin. Normally the treatment takes 5 minutes per injury, more or less, and it is completely painless for the patient. Patients can lead a normal life from day one. They only have to use sunglasses and povidone iodine 3 times a day during the first week. I check everything is okay after 24 hours before let them work again. Yes, here, after a week, we can find the wound with or without scab. It's very important to explain to the patient not to remove the scab because it protects from the sun and infections and reduces the scab risk. My experience after the first month is 100% satisfied patients with full recovery with only 1 session and no case of hyperpigmentation or scar. Here, for me, this picture is the most important in the presentation. You have before the surgery, the typical xanthelasma, then the first week with the scab, not to remove it, and then in 1 month, all the patients are really happy and saying that they didn't feel anything and the skin is completely recovered. My longest follow-up till the date is 9 months. During this time, there have been no relapses or complications. Patients must know that there can be relapse with any kind of treatment because of that, they should avoid stress, smoking, and try to have a low-fat diet and do sport frequently. In conclusion, Jet Plasma Lift is a very safe and affordable treatment with minimal learning curve, and the patient will know the result from the first day. They usually say to me that I recommend it to everyone who has it. Thank you very much, and if you have any question, I will wait in here for there. Thank you.
Thank you very much, Dr. Melian. Very fast presentation. That is good because a little bit late. So thank you for being really going to the point. So at this moment, Dr. Ivana Masesova from Czech Republic, whenever you want, you can explain us your experience. Thank you.
So good evening. Thank you for invitation. My name is Ivana Matsejova. I work as an ophthalmologist in Prague, and I would like to share our experiences, me and my colleagues from Slovak and Czech Republic, with the treatment of the entropium, ectropium, and trichiasis with Jet Plasma Lift Medical. We have 3-year experiences, and I would like to thank my colleagues from Czech and Slovak Republic for sharing their cases and photos. So indication for the treatment are treatment of mild and no severe forms of ectropium and entropium. It's suitable for the patient with a blood thinning drug because you avoid a bleeding. So the treatment of entropium involves a local anesthesia. We are using 1% of lidocaine, and on the device we use intensity 7 or 8, but usually the maximum of 8. And the procedure involves dot by dot technique on the skin part of the lower eyelid in the line under the margin of the eyelid in a triangular shape, or you can also treat it whole area of the eyelid also in the triangular shape. It depends on the severity of entropium. There is also a possibility of retreatment if the treatment is not if it's needed, and the result of the treatment is carbonization of the eyelid. That's due to the eversion and the reduction of the entropium. Let me introduce the case number 1. This is the patient, 70 years old, with the entropium of the lower eyelid on the right eye. We choose standard protocol with the dot by dot method. This is the picture before. You can see spastic entropium, and the second picture shows immediately after procedure. You can see immediately result after procedure that there is a eversion of the lower eyelid. And the third picture is, oh, I'm sorry, 1 month before, after. The cases too, it's a little bit modification, is from my colleague from Slovakia. We use also dot by dot technique, but like you can see, it's in the whole area of the upper eyelid, a little bit in the triangular shape. And immediately after the second picture and the third picture after 3 months. And this is my patient, 72 years old man with an entropium on the right eye, spastic entropium. The second picture immediately after the procedure with a dot by dot technique in the triangular shape, and very nice result after 6 months. You can see that it works. So let's see please the video from the procedure. I hope it's entropium. So disinfection, non-alcohol disinfection. Local anesthesia. And in the line under the margin of the lower eyelid, we are doing small spots, dot by dot technique in the triangular shape due to the eversion of the eyelid. So it takes approximately 5 minutes, so it's fast and safe for the patient. The second treatment is treatment of the ectropion. The procedure is the same. It involves local anesthesia. Intensity on the device, we choose 7 or 8, so the same. And we use also dot by dot technique. Here, in the case of ectropium, we are treating the tarsal conjunctiva in a triangle shape, or we can use a modification that we are treating from tarsal conjunctiva and from skin part on the eyelid. The best result we receive if the ectropium is in the area of the lacrimal punctum. This is the case number 1, our 91 years old patient. She comes from ectropium at the area of the 3-point on the lower eyelid on the right eye. It was performed surgery, but with not sufficient effect. So we decide to apply jet plasma treatment 2 weeks after the surgery. We treat conjunctiva, tarsal conjunctiva in a triangle shape with dot by dot method. And this was the eyelid before the procedure or treatment, and this 1 month after. So the result was more than effective and the patient was very satisfied. This is the modification of the protocol that we use not only treatment from the tarsal conjunctiva, but also we treat opposite on the skin part, also in the triangular shape. So there is a possibility of modification and also for retreatment. So let's see the video from the treatment of ectropion. So at first, disinfection of the skin without alcohol. Local anesthesia with 1% of lidocaine. Also anesthetic in the conjunctiva, tarsal conjunctiva. Protect for the cornea. And it's important to dry the area, to have a dry area for the treatment, and small dots, dot by dot, in a triangle. The best results we receive in the treatment of the ectropium in the area of lacrimal punctum. This patient is 1 year after the procedure and without problems. And also dot by dot technique on the skin part of the lower eyelid in the line under the eyelashes of the margin lower eyelid. And also triangular shape. This due to the discarbonization due to the aversion and reduction. We have noticed no complications and no side effects, and there is a possibility of retreatment, repeating the treatment if it's not satisfied or effective. And this is how it looks after the treatment. And the last topic will be the treatment of trichiasis and dystichiasis. In this procedure, we are using intensity from 5 to 8. It depends on the severity, and doctor can choose from the on the severity of the case. We have to avoid burning of the eyelid margin, and also is needed local anesthesia. It's perfect if you can do this procedure under the microscope, but it's possible also to use a slit lamp. At first, it's important to avert the eyelid, then insert the ophthalmological applicator to the hair duct as deep as possible, then switch the device for 1 or 2 seconds, and this will destroy the hair follicle. Please let's see the video from the treatment. So we protect the eye. We use a protector for the cornea to avoid. And this is the best is to use this procedure under the microscope. So insert the tip. This is the ophthalmological tip. Insert into the duct. This is modification that we insert it with a pincet. I have seen the question if there is some complication if we burn the tarsal conjunctiva. We have noticed no complication and no destruction of the meibomian glands. It's not too easy to find the duct. But here is successfully there are no limits for how many follicles you can treat. This is the case of our patient that we have seen the video. So the procedure involves local infiltration anesthesia. We use 1% of lidocaine, use protection for the cornea, and plasma pen with the applicator. Point application by puncture in the direction of eyelashes grow. insert to the duct and pull out without resistance. The intensity is from 3 to 7. This is from my colleague, but it's possible to use also from 5 to 8 intensity. Thank you for your attention and have a nice evening.
Thank you very much. Thank you, Dr. Masijova. It's been very, very interesting as well. And now it's a turn of the last presentation of Dr. Ridla Puente. Let's see. Hello.
Hello.
Perfect. Now we are seeing your presentation.
Thank you very much to all the attendees and to the organizers, especially. For me, it's a pleasure to be participating in this very interesting meeting. It's a little pity that I'm taking care about the, let's say, the saddest of all indications. It's a nagging condition of the dry eye disease, which is so common that we, in fact, whatever specialty we are dealing with, either if you are a cornea specialist, a retina specialist, you need to take care of your dry eye patients as a part of a holistic concept of the ophthalmology. So let's go ahead with my presentation. I'll try to catch up a little because we are not very good in the schedule, and I acknowledge no interest, no conflict interest with this device. And we are going to deal with the definition of dry eye disease according to the TFO's dry eye workshop in 2017, where the dry eye is considered a multifactorial disease of the ocular surface with a loss of homeostasis of the tear films, with symptoms, tear film instability, hyperosmolarity, and ocular surface inflammation, and thus leading or accompanied by neurosensory abnormalities that we all know. The prevalence is so high, it looks to me that this 11% in people over 40 years old is a little conservative. Women account in a ratio to 3 to 1 when compared to men, and increases with age up to 70%, 75% in people 60 and older, and with a high impact in those dedicated with any kind of work with computer. You need to stop and put some drops and go back to the work, so you are causing a certain economic impact with loss of performance. 70.3% of dry eye disease is related and secondary to dysfunction on the eyelids glands, on the meibomian gland disease. And this includes the subtype of evaporative type. So when you're dealing with a high prevalence of this accompanying disease to any of the others, any specialist, subspecialist, and general practitioner in ophthalmology needs to deal with it. And if you are trying to ignore it, you are going to deal with high risk of unfortunate results like those that you obtain when you put a multifocal intraocular lens when your ocular surface is not perfect. So far, treatments available, we all know about them, the drops, the eye drops, lubricants, ocular hygiene, warm apposites, anti-inflammatory drugs and antibiotics, whether they are topical or oral, and physical methods. And we are joining this sub-chapter of the methods with the meibomian drainage, the thermal pulse therapy, the IPL, the probing of the introductal gland, the eyelid debridement, and the removal of the biofilm with the Blefex device. And we have the newcomer, the jet plasma leaf device, with two different techniques. For the mild and moderate cases, we are going to propose a contact technique which has very good results, and you don't need local anesthesia. And for those cases that you are going to lose the follow-up and you need to perform a very effective treatment at once, we are going to use the contactless technique with the golden tip. The basics of the physics are going under revision, and I've been told today that a new video is coming from the company. So let me only remind you about the thermal stimulation, and keep in mind this new concept of the electroporation, a reversible electroporation, because this is going to come over and over, and with new basic science support. And this accounts for the effect, the beneficial effect on the cellular membrane depolarization too, and the upregulating of the inflow and outflow and reorganization of the different ions in either part of the cellular membrane. So there is an enhancement procedure that upregulates the imbalance of the electrolytes in each side of the cellular membrane. So the dermatologists, the cosmetologists, and most of us people like the proficient doctors that have enhanced our knowledge of what is happening with the aesthetic approaches, we are all aware about the stimulation of the collagen production, improvement in vascular and tisular and vascularization, even in the mucosal side, blood perfusion and elasticity. But we are going to approach the dry eye disease itself. We gently disinfect and apply the anesthetic drops, and we use a non-conductive gel, which is this here, and we choose the silver tip of 3 millimeters to apply it over the surfaces with power levels from 5 to 8, according to the tolerability of every patient. We spend 2 minutes per eyelid, and this allows us to make it very fast without the need of special appointments for the patient that they tend to reject, especially in these critical moments of our lives. So we use a conductive gel for the application, and see here in the video how we can apply it in the eyelid margin. Some authors emphasize on the inner part of the mucosal side, and some other authors emphasize on the treatment on the skin, on the external approach. In either case, it's very important to realize that we need to treat the eyelid margin. It has a beneficial effect by itself. You can see here the gel, which is vaporized, and some small bubbles. And here is the internal approach of the treatment. We can do it circularly, or we can do it vertically. The issue is treating with enough energy all 4 eyelids. Do not forget the upper eyelid. So in cases that you are going to lose the follow-up, the blepharitis is active, some people might choose anesthetizing the eye, as here, and using the golden tip with a little lining that gently contracts all the surface and causes transient thrombosis, thus enabling improving the extracellular matrix surrounding the glands of the eye, and that also will induce an improvement of the aspect of the eyelid according to different publications. And the basic science and the tisular effects have been explained already and advanced by Dr. Vicente Rodriguez, one of the developers of the technique and the pioneer. And here, our colleague, Dr. Semanova, was the first to document in a paper how the treatment is going to improve in cases of blepharitis in the mild forms, the parameters regarding the stability of the tear film. That documentation will promote a group of us, and we decided to choose amongst the two choices. Instead of the contactless, which is a little painful with a local anesthesia, we decided to approach with a contact technique which is not painful, is so fast and efficient, with the little inconvenience that we decided to apply 4 sessions. Therefore, our colleagues that I need to acknowledge, directed by Dr. Semanova, they address this randomized 2/3 to 1/3 treated versus controlled patients in a simple blind independent observer manner, with the control group being a sham group. So the control group had a manual debridement of the eyelid margin without the activation of the plasma energy. This is a call for an invitation to join every general ophthalmologist in your practice the use of this questionnaire of the Ocular Surface Disease Index that we give to the patients, and we transform it with the sum of the scores here into the number of OSDI, and we then choose this parameter as the primary objective of our study in the dry eye disease, the OSD score. And we saw from the beginning the treatment group, when compared to the treatment high scores of the OSD, an immediate improvement that stayed over the weeks that follow the last treatment until the cut of the study 12 weeks after the last treatment. In contrast to this, we could see the control group who had the removal of the eyelid margin debris and eyelid margin biofilm by the mechanical effect without application. We could see an initial improvement, but it stayed about the same for all the period. That resulted in a very significant improvement when we compared the paired data of the treated group, and the control group did not result on a significant improvement. And when we put those numbers into a percentage of improvement, we see that we can improve a little less than 40% from the beginning, up to more than 60% after 12 weeks after the last treatment. While in the control group, it stays about the same all the period, with a slight and transient improvement in the very first weeks. So if we put next to the other the improvements, you can see here the lesser amount of improvement when compared to each other is in the 1 week post-treatment, which is non-significant. This due only to the little amount of the intermediate analysis. The control group had too little numbers of patients, but I'm sure that the final study at the end, we will see high significant difference even in this case where the mechanical improvement of the control group applies. So I'm a user, present user of IPL. I think that we host most part of the available techniques for the dry eye disease. As general ophthalmologists, I'm insisting on this, but this is what it happens when you start dealing with jet plasma. We have decreased 70% of the indications. The dedicated nurse is ready to move somewhere else. This is a joke. And this is because we have been substituting this treatment with the jet plasma, and even in those cases that we still have neurosensory problems regarding the dry eye disease without any evident disease in the surface. In those cases, we tend to use the newcomer, the insulin drops. And as a final operational analysis, I would suggest you to apply it yourself, because if someone else is applying the treatment, they will not hold the same trust as you would do it, and you cannot apply the same fee if the nurse is doing that for you. The surgeon's fees will avoid cosmetic fees that are the usuals that you can apply when somebody else is going to treat the case. And it can be done on the run without the spatial rescheduling of the patients. And with the golden tip and with the contactless technique, we even are able to improve very resistant, long-standing severe blepharitis conditioning or preventing ocular surgery. So treat them before and you will have a much better condition for the future. Finally, as a last consideration, seeing is believing, but stop hearing complaints is more important for us. And thank you all for your kind attention and open for discussion.
Okay, thank you very much, Dr. Ruiz Lapuente. I think now is the moment of discussion. If any one of the participants, I would ask, please do not connect the microphones, but please, I think it would be better all the questions can be written. And all the organizers, if you can connect your cameras and your microphones, so you're all ready to answer the questions.
There was a popping up question regarding the interval between sessions. The one that it was included in the pilot study, it was 1 week in between sessions, and my recommendation would be to stay with 1 week unless we document in the future that sessions 2 weeks apart are equally efficient.
And for working with the golden applicator, how long time you recommend for the second procedure? In blepharitis, for example, Carlos?
As we discussed before, we tend to use the golden applicator whenever you have a severe problem, or either you are not going to see the patient for a long while. So it's a rescue second treatment appointment that I never tend to schedule before 1 month. Never before 1 month.
Ivana, what do you say with the golden applicator? Or you use the same procedure 1 month, or you wait more time?
Now I am using more silver tips because of the comfort. It's more comfortable for the patient, and before we have used this golden tip, but it involved to use anesthesia for the patient. It was painful, hematoma. They were not satisfied. So now I am much more using these silver tips in this cases.
You mean that we can use the silver applicator for all the cases, or in some cases you think that this will be better to use the
as Dr. Lapuente has said, that in more severe form it's better to use a golden tip. So I think so. I agree with this. But usually it was just one session with this gold tip.
Okay, there is a question about recommended after finishing the blepharitis treatment. They are asking if cold compress or warm compress.
I just reply, I prefer cold compress. But you don't really need it that much. I need to acknowledge.
Okay.
Yes, before the blepharitis is work, the best for treating blepharitis before the jet plasma. But I think the same, Carlos. After the procedure, maybe the cold will be a better option.
I lost part of the question, please. Could you repeat it for me? I misheard part of your question. Could you repeat it for me, please?
No. Yes, I think that the same you think or use after the treatment using the cold compresses will be better, but before the treatment I recommend the warm compresses.
A very interesting question. It's about the pain. The patients that are tolerating different intensity. They are saying that our patients do not accept intensity 7 with silver tips or maximally 5. Asking if it's individual.
I think it is. It is individual, but the trend is to go from 5 upper and upper. It's not that cumbersome, so it probably most part of the patients will reach up to 7, saying, well, they are feeling a little current going on, but it never precludes, and you can see it even in the pilot study. Probably some of our colleagues which use the device without putting the plasma energy on, those colleagues of us could reassess. Probably the comfort is about the same when they are using 5, 6, 7, or very little difference between using the energy or not using it. It's a matter of manipulation of the eyelid itself. I'm not using a routine painkiller in advance unless I know the profile of the patient and I fear that he will be delaying all the treatment, because I tend to offer the treatment as a popping up treatment that I don't need to stop my consultation. So as long as I'm not having the patient waiting at the waiting area, I tend to offer if I consider that this is going to be a little uncomfortable for that specific person.
Albert, I have a question for Tadaaki Yamada. Tadaaki, you are a very good refractive surgeon. I know that you have experience in refractive surgeon, but normally people know you speaking about oculoplastic surgery. Currently, how many percentage of blepharoplasty in your office you recommend plasma, or you can treat with plasma or with conventional surgery? How, more or less?
Yes, that's a good question. Always the patients who come to my office are looking for plasma. For 10 patients that come to my office for jet plasma, 6 I recommend jet plasma, and 4 case I recommend the blepharoplasty, the conventional, because they have fat or darker skin, or heavier skin, or eyebrow is lower, so I have to operate an eyebrow together of blepharopathy. So most of the cases, about 6% who want the jet plasma, I do the jet plasma, and 40% I go to the surgery.
I have another question.
It's difficult because who want the more results, and that results last more, because jet plasma, the results last about 3 years, 2 or 3 years, and the surgery, the results last about 8 or 10 years. So who want the more visible result, go to the surgery. But young patient with no fat is a good option to do the jet plasma. But there is some colleagues that take the fat off and then treat the skin with jet plasma at the surgery.
In Brazil, Tadaki, currently there are more or less 2 million Japanese population. It's the first country with more Japanese outside Japan. No?
Yes.
Do you recommend something special condition for treating Asian people, Chinese, Japanese skin? We need to do something different.
Yes, I recommend the preparation, the skin, and I tried the hybrid techniques for all of them. Hybrid techniques for Asian patients.
Low energy?
Yes, I tend to use 6 or 7. If you use the plasma pen, you can put the intensity 5. The dot is very fast.
In this group, you prefer to do 1 procedure or 2 procedures?
Yeah, I recommend 2 or some case 3 sessions.
Good. There's a
only,
question.
Only in Japanese population, no? Only in in Asian group. Okay.
Phototype 4.
For Dr. Yamada. It's about if they're asking if you noted that there was a reduction of fat. I mean, I suppose they're talking about the lower eyelid.
Yeah, yes. It's not the indication for lower fat, eyelid fat, but the skin tightening put the fat back. But the fat is there. Is the best choice is to do take the fat off transconjunctively and then treat the skin with jet plasma.
Yes, I would like to pose a question for Ivan. After Ivana's presentation and after Dr. Yamada's presentation, I realized that sometimes when I remove the fat, I would be able to obtain much more natural results if I tend to avoid the lateral tension, canthal tension, instead of doing it surgically. I would rather reconvert it into a dot, let's say, a strengthening procedure for the inferior eyelid.
Mm-hmm.
And for Ivana, do you have how much percentage of recurrence of the dystichiasis and tychiasis do you have?
We have only few patients for this treatment, so I can't tell how percentage is it, because it was the cases of my colleague, and if you are treating on the slit lamp, it's with difficulties. So I'm sorry, but in percentage, I can't tell it.
There is another question here about the the downtime, how to approach to less downtime. They're saying if, for example, shorter discharge time instead of stay 3 seconds, or use silver tip for scanning instead of golden tip. I mean, I see that the question is how to reduce the downtime. I would say
yes, the best is to think 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. This is my recommendation. 1, 2, 3, and chain the dot. 1, 2, 3, chain the dot. 1, 2, 3, chain the dot.
I have a question. Sorry, I have a question for Milan. I saw that in your cases of chantelasma, you are dealing with very deep ablation of the epidermal layers, and I've noticed at the very beginning that probably I was needing 2 sessions when I only achieved to the yellowish layer of the lipids and cholesterol. But then I realized, and I sent some photographs to Albert, that even with 1 session, without physical liquefaction of the yellowish deposit, you can achieve a full recovery after 15 days. So, do you tend to produce a visible scar at the end of the procedure, or can you go ahead with lighter treatments?
After the procedure, I see the black bed, and it turns red. And the first day it's completely red, only red. And in the first week, it's getting black and black, and you can see the scab. Maybe not, more or less 7 or 10 days. Then it goes to improve, and in my case, there was no relapses, no hyperpigmentation, and any problems.
Thank you very much.
And we need to explain the patients that will be better to have the black, because for in the post-op immediately it's better to have the black on the skin, and we need to explain this to the patients.
Can I ask about the xanthelasmata? Do you see any difference if the xanthelasma is much more on the surface, or it's deeper? Is there any difference in the treatment that you have to repeat it if it's much more on the surface?
It's easier to treat when it's not deeper, but with only 1 session, it doesn't matter the deeper. You can reach the skin under the xanthelasma, and you won't have relapses or any problem. In my cases, all the xanthelasmas with only 1 session, it will full recovery. It doesn't matter the skin, the deeper, and the size of the xanthelasma.
Carlos,
Yes.
what do you think about you think that we can have future for treating dry eye disease only on the skin or with jet plasma, or you consider in the future we will need to use all time the maybe combine the skin on the conjunctiva surface, but treating, for example, mild or a little moderate cases of dry eye disease secondary to meibomian gland, you can think that we can in the future treat only on the skin and combine the margin, skin and the margin
Yes.
with the 5 millimeter silver applicator.
I'm a little confused. This is the only point, because both systems work. So I started by the skin, and I followed your approach, and we even participated on an early design with Dr. Rodriguez of a different probe. But I see whatever you do, if you do the eyelid margin, it's going to improve.
Mhm.
I can say that I've seen also. I've been in a treatment of chalation also treated for at the side of the skin as well. So it is also working in that sense. Sorry, Ivana.
Yes, yes. Yeah, very, Ivana, what do you think about the chalation? Do you have some experience with chalation?
I would like one more question to Dr. Lapuente. So the patient which are treated with silver tips, they tolerate intensity of 7.
Yes, as a routine.
As
Because most part of I wouldn't say pain, the discomfort of the patient relates on how much are you pulling from the eyelid and how do you deal with the eyelid tension.
Mhm.
You know, we all
you are
know.
doing faster this, or it
No,
doesn't depend.
the speed on the movement doesn't account for a huge difference. So it's about the tension that you put on the eyelid, and but in never in any case I found that is a limiting factor. So I tend to use from 6 to 7 in most part of the cases, because I tend to think that might be with 5 or lower, it might be a useless procedure. I don't know. So in the future, we will need to look at this specifically. Once we know that whatever you do is good for the patient, probably with 2 sessions you have enough improvement. So in the future, we are going to go deeper and see how many sessions, the lesser the sessions, the interval, and the amount of energy required. But keep in mind that most part of the mild or moderate inflamed eyelids account for a certain eyelid swelling. So in cases of swelling, you have a thicker eyelid, and probably in those cases, you don't need you will need to use more powerful settings of the machine.
Thank you, because no for my patient tolerate intensity 7, so I just was asking.
Well, I
How are you
will
doing?
I will do a sequence. Try with a little painkiller, uh, just psychological support,
Yes.
but it's not painful at all.
Dr. Ivana, I have a question. For a treatment of ectropium, comparing only inside the conjunctiva and the modified is more efficient treatment for ectropium, or did you try treating more parts inside the conjunctiva instead of the skin?
In our results, the more efficient shows that only just tarsal conjunctiva when was treated, and in this area of the inner part area of lacrimal punctum, this result was much more better than in the modification of from the skin and the tarsal conjunctiva.
Yeah.
Ivana, once more, and the recurrence of the entropion after your treatment or the ectropion?
You mean time of the recovery, or?
No, recurrence. Do you think that these results are going to stay for a long time, or do you compare with or other surgical procedures with the tarsal strand counts for a more permanent results?
One of my patients, I was repeating after, I think, after 4 or 5 months, once more. And it was a severe form, spastic form of the entropium, so it leads to the surgical technique. But the patient was happy that he can be without this surgery for approximately 6 months. Yeah.
Perfect.
So it depends. Mild form, I think it can take 1 year. But if it's a much more severe form, so it's needed to repeat it. Approximately 4 or 5 months.
There's another question. I think, I don't know if any of you has the experience of mixing. I'm talking about blepharoplasty. If mixing the silver and gold, because they are saying, what about, as you said, Dr. Yamada said that the scanning with the golden tip is causing the more downtime. Then they are proposing if doing the scanning in contact with silver and then doing dot by dot. I don't know if any of you have experience in that sense. It's like a mixing the two techniques.
What I do as I said, the retreatment is after 3 months. So after 1 month, if the patients complain that it's not so good, you can start using the silver tip and put the drug inside the skin using the silver tip. Weekly, you can do. And after 5 or 6 treatments, about 1 month and a half, before 3 months, sometimes it's not necessary to do the enhancement. So, as I said, you have to wait 3 months to do the retreatment. But after 1 month, you can start doing the silver tip to improve your results.
Okay.
Is the key.
Okay. Okay, I think, and I don't know if there's any other question, but I think we are reaching 2 hours webinar. I think it's quite enough for all of us, for all the attendants and for the presenters, of course. So I think that if there are no more questions, I would like to thank you. Thanks you to all of you for your fantastic presentations. It's been very, very useful. And I hope all the audience also enjoyed it. And I don't know if Martin, are you there? Thank you also to Compex for the organization. Hi, Martin. Thank you to Compex for the organization. And if you want to say the last words, please.
Yeah, I think all what should be mentioned was already mentioned. Also from my side, thank you very much to all participants who connected. Also, thank you very much to all doctors who held today their presentation. I think it was really nice, and also thank for the participants for the questions. They were useful, and I hope that we will see each other again soon.
Thank you.
Thank you.
Thank you.
So
Thank you.
for all of you, have a nice evening, afternoon, morning, or every part of the day you have. And for me, have a nice evening.
Nice
Thank you.
weekend for everybody.
Bye, everyone.
Bye.
Thank you.
Bye-bye.
Bye bye.
Thank you.
Bye bye.